Hello and welcome. Today, we're diving into a less common but significant manifestation of sarcoidosis, renal sarcoidosis. We'll explore what it is, how it affects the kidneys, and what can be done about it. Renal sarcoidosis occurs when sarcoidosis, a systemic inflammatory disease, affects the kidneys. While the exact cause of sarcoidosis itself remains unknown, it's believed to involve a combination of genetic predisposition and environmental triggers. These triggers might include infectious agents or other substances that initiate an abnormal immune response in susceptible individuals, leading to the formation of granulomas. The pathophysiology of renal sarcoidosis primarily involves the formation of non-cascading granulomas within the kidney tissue. These granulomas are clusters of immune cells that clump together. They can infiltrate the renal interstitium, which is the space between the kidney tubules. This infiltration disrupts the normal kidney structure and function. A common consequence is hypercalcemia, or elevated calcium levels in the blood. This happens because granulomas produce 1-alpha hydroxylase, an enzyme that converts vitamin D to its active form, calcitriol, which enhances calcium absorption in the gut. High calcium levels can then lead to nephrocalcinosis, the deposition of calcium in the kidneys, causing further damage. Granulomas and nephrocalcinosis can impair the kidney's ability to filter waste and regulate fluid balance, potentially leading to acute kidney injury or chronic kidney disease. Renal sarcoidosis is relatively uncommon compared to pulmonary sarcoidosis, which primarily affects the lungs. It's difficult to pinpoint exact figures, but studies suggest that kidney involvement occurs in a small percentage, possibly 1–5%, of all sarcoidosis cases. It is more common in individuals already diagnosed with systemic sarcoidosis and may be overlooked if the renal manifestations are subtle. The signs and symptoms of renal sarcoidosis can be varied and often subtle. Many patients may be asymptomatic, especially in the early stages. When symptoms do occur, they may include fatigue, bone pain, increased thirst, and urination, which results from hypercalcemia. As kidney function declines, symptoms like swelling in the legs and ankles, edema, high blood pressure, and changes in urine output may become apparent. In some cases, patients might experience flank pain or hematuria, blood in the urine, but these are less common. Diagnosing renal sarcoidosis requires a combination of clinical evaluation, laboratory tests, and imaging studies. Blood tests can reveal elevated calcium levels, hypercalcemia, abnormal kidney function, elevated creatinine and BUN, and potentially elevated levels of angiotensin-converting enzyme ACE, although this is not specific to renal sarcoidosis. Urinalysis may show proteinuria, protein in the urine. Imaging studies such as ultrasound, CT scans, or MRI can help visualize kidney abnormalities. However, the definitive diagnosis usually requires a kidney biopsy, where a small sample of kidney tissue is examined under a microscope to confirm the presence of granulomas. Furthermore, the biopsy must exclude other causes of granulomatous kidney disease, such as infections. While renal sarcoidosis doesn't have subtypes in the same way some diseases do, it can present with varying degrees of severity and impact different parts of the kidney. Some patients may primarily experience hypercalcemia, induced kidney damage, while others may have more extensive granulomatous infiltration. The primary goal of treatment for renal sarcoidosis is to reduce inflammation and suppress the immune system. Corticosteroids, such as prednisone, are the mainstay of treatment and are often effective in reducing granuloma formation and improving kidney function. Immunosuppressant drugs, such as methotrexate, azathioprine, or mycophenolate mofetil, may be used in addition to or as an alternative to corticosteroids, particularly if corticosteroids are ineffective or cause significant side effects. Treatment for hypercalcemia includes hydration, diuretics to increase calcium excretion, and medications like bisphosphonates or calcitonin to reduce calcium release from bones. In severe cases of kidney failure, dialysis may be necessary. Regular monitoring of kidney function, calcium levels, and blood pressure is crucial during treatment. Since the cause of sarcoidosis is unknown, there are no specific preventive measures for renal sarcoidosis. However, maintaining a healthy lifestyle, avoiding known environmental triggers, if identified, and promptly addressing any symptoms suggestive of sarcoidosis may help in early detection and management. The prognosis for renal sarcoidosis varies depending on the severity of kidney involvement, the promptness of diagnosis, and the effectiveness of treatment. Early diagnosis and treatment with corticosteroids and/or immunosuppressants can often lead to significant improvement in kidney function and prevent long-term damage. However, if left untreated, renal sarcoidosis can progress to chronic kidney disease and, in severe cases, end-stage renal disease requiring dialysis or kidney transplantation. Recent research has focused on identifying specific biomarkers that can predict the risk of renal involvement in patients with sarcoidosis and on developing more targeted therapies to reduce inflammation and prevent kidney damage with fewer side effects.